Hello everyone. Welcome to the April 2013 Fixed Wing Monthly Education. This month we are going to do this presentation on neurogenic shock. This presentation spawned from a transport that I did late last year and put the presentation together afterwards and never did present it, so I'm going to go ahead and take this opportunity to do so. Objectives of this presentation will be to define neurogenic shock, give the clinical presentation of it, differential diagnosis, and pre-hospital care and treatment. So what is neurogenic shock? Neurogenic shock is a distributive type of shock resulting in hypotension, occasionally with bradycardia, occasionally being key there, that is attributed to the disruption of the autonomic pathway within the spinal cord. Incidence of neurogenic shock. And before I get into the numbers, I want to go ahead and tell you where these numbers came from. They came from TARN, which TARN is short for the Trauma Audit and Research Network. They are 50% of trauma receiving hospitals in England and Wales, which collect data on patients that are either A, admitted to those hospitals, and they stay admitted for 3 days or longer. They are B, admitted straight to an ICU, or C, die within 93 days. The data that you'll see was collected between the years of 1989 to 2003, so 14 years of data that they use. The exclusion was patients over 65 that had isolated fracture of the femoral neck or pubic ramus, and those with single uncomplicated limb injuries. So here is what they found in those 14 years of collecting all this information. C-spine injuries result in a 19.3% chance of suffering from neurogenic shock. T-spine, 7%, and lumbar cord injuries are 3%. So you can see that the higher the level of injury, the greater the chance of suffering from neurogenic shock. All of the information collected from TARN is shown in the next two tables. Table 1 here details the patient's their ages, and their ISS. Just to note, ISS is a injury severity score. It was established to assess trauma severity. It correlates with mortality, morbidity, and hospitalization time after trauma and is used to define the word major trauma, the term major trauma. There were 926 patients that sustained spinal cord injury, 490 of those, which is 53% of these has sustained isolated spinal cord injury with no other injury. The vast majority of these, 98.2, so just about almost all, were injured by blunt trauma. Now, breaking down the information that's shown in this table, the years, you can see that all of our ages are roughly the same average age, 41 to 33, only an 8-year difference in age between all three categories. The ISS is the same in all three, and the patients that died a lot higher in the C-spine group and as compared to the T or lumbar spine. Table 2 details the systolic blood pressure and heart rate in these patients. It also shows the number and percentage of patients who have hypotension, a low heart rate, or both. Breaking this down a little further, you can see that the patients' systolic blood pressure and the cervical injuries were not a lot lower, but significantly enough lower than the thoracic or lumbar. Also, the heart rate is 10 below those in the thoracic and 13 in the lumbar. But the last row here, the systolic blood pressure less than 100 and the heart rate less than 80, it is a significant jump in the patients with cervical injury versus those with thoracic or lumbar injury. And that 19.3% is very similar to the 18.9% of the patients that died in the previous slide here. Clinical presentation. Now, these patients will present with hypotension, bradycardia, warm, dry skin, and the symptoms can last 1 to 3 weeks. All of this is subjective to the patient. It's really different, as you could see in the previous slides, that different patients will exhibit different ways. So This not going to be clear cut every single time that the patients present with hypotension, with bradycardia. They have warm, dry skin. There's not a lot of data that exists that show you the hypotension, bradycardia relative to time, but several studies have been performed on animals. Those studies have found that there is a first phase of hypertension and bradycardia, which only lasts a few minutes, and then the profound and persisting bradycardia may take about 2 hours to develop. So what they found here is this physiological reaction that takes place is kind of a step-by-step thing that happens. And the initial thing that's going to happen is you're going to have the spinal cord injury, and right initially after the spinal cord injury, there's going to be a massive sympathetic stimulation and reflex parasympathetic activity that's going to last 3 to 4 minutes, mediated by the alpha adrenergic receptors. The patient then develops reflex bradycardia and tachyarrhythmias as a result, and sometimes severe hypertension. This hypertension is due to the fact that you had this injury and your adrenal glands are releasing a massive amount of norepi and causing you to get hypertensive. After this immediate response to the trauma occurs, there's a decrease in the sympathetic activity due to the interruption of descendant sympathetic pathways. Then, as a result of that, the cardiac output and total peripheral resistance decrease. CVP remains unchanged, and then, as a result, the patient is prone to bradycardia, hypotension, hypothermia. There is a human study that shows that the greatest prevalence of bradycardia was at 4 days. There's also an existing theory that says that many patients are reaching the ED before the maximum bradycardia and hypotension have developed. For us, that obviously means that we may not see the full extent of these two physiological signs, or if we do, it may be on the interfacility transfer several hours, even days after their initial injury. The next 2 slides are probably the most important part of this presentation and is the reason I'm doing this presentation, and we'll discuss it further whenever I get to the case study. But diagnosis and differential, the diagnosis of neurogenic shock, and this is very important, should be one of exclusion. Neurogenic shock must be differentiated from other types of shock, particularly hypovolemic, and that is really important in a trauma patient. Can't stress that enough. When dealing with trauma patient, one must always assume that any hypotension is a result of ongoing blood loss. Pre-hospital care and treatment, a lot of this is going to be just like any other trauma patient that we go and take care of. We're going to rapidly identify their life-threatening injuries and treat those in order of importance, A, B, and C. Spinal immobilization, most of our patients are already there. Sometimes that interfacility guy, they like to get them off the board pretty quickly, and if that's the case and you suspect they have spinal cord injury, obviously we're going to put them back in there. Maintain adequate MAPs of greater than 90 systolic. This is directly out of our protocol. Fluid challenge with 500 to 1,000 milliliters of normal saline or LR. Dopamine 2 to 20 mics per kg per minute. For patients that may have the bradycardia, they may respond to 0.5 to 1 milligram of atropine. Also keep in mind that those patients may respond with your dopamine administration. Also treat for possible hypothermia, and how we're going to do that, it's going to be with warm fluids, blankets, and trauma cocoon. Rapidly transferred to a level 1 trauma facility for definitive treatment. Considerations. Consider a Foley, and also note that the use of high-dose solumedrol therapy, you may see it when you go get these patients, but it is not a recommended treatment for neurogenic shock by most level 1 trauma facilities, definitely not by Dr. Swanson. Some of the studies have even showed that solumedrol is harmful for the patient. So getting to the case study. This was a patient that I went to get late last year sometime. It was an 18-year-old male that was unhelmeted when he was involved in a motorcycle accident. Upon EMS arrival, it was discovered that patient was in PEA arrest. CPR was initiated, King airway was placed, and patient was transported by EMS to referring. Upon arrival to referring, patient was still in PEA arrest. Patient received ACLS protocols, epinephrine for condition until he had return of spontaneous circulation. Total time from initial arrest to ROSC was approximately 15 minutes. Patient had 2 large bores placed. He had normal saline infused. Neck and chest x-rays, bilateral needle chest decompressions were performed, and pericardial centesis. C-spine x-rays revealed that the patient had C1, C2 hangman's fracture. During this time, patient had multiple 4 to 5 VF arrests, which he was defibrillated for successfully. Amio drip was initiated. Other drips initiated include Solumedrol, dopamine, levo, and the highest heart rate was 88, lowest BP was 0, lowest GCS 3. So we get on scene and the referring physician is in the room. The room is kind of a hectic atmosphere. The mom is in the room. I think she was a nurse, and she knows what's going on with her son. She knows that he has a very bad injury that he probably will not survive. But anyway, the referring gives the report, and he states in his report, one of the very first things he says, patient is in spinal shock, and Solumedrol is being given per spinal cord protocol. I think he said that he was given the bolus per the protocol. So we found him lying unrestrained on a long, rigid backboard. He wasn't moving. C-collar was in place. Patient was intubated, being ventilated by RT, hyperventilated by RT at 35 to 45. Physical assessment. Head, he had periorbital ecchymosis. Neck, he had soft tissue swelling on the anterior side of his neck, the right anterior side being greater than the left anterior side. Posteriorly, he had no step loss or deformities. Chest, abdomen, and pelvis were all great. No instability on his chest, crepitus, subq, bruising, nothing to indicate that he had any kind of trauma to the chest. Abdomen, the same thing. It was just as you would expect a normal person. Soft, non-distended, no bruising or mass. Pelvis was stable. Back had some abrasions, but nothing significant. Extremities, also no lone bone fractures. He did have some abrasions to the right upper extremity. No active bleeding or anything like that. The skin was cold and pale. Vital signs upon arrival were heart rate 85, sinus rhythm, BP was 62 over 32, saturations were 98%, GCS was 3, and they were starting that dopamine drip for that pressure that you see there, 62 over 32. Transport. We arrived and continued all current therapy. We also initiated a Levophed drip at 5 mics. Patient's BP responded to all vasopressors and never got below 100 systolic for the rest of the transport. We were even able to titrate the dopamine down to 12.5. We packaged the patient up, transported to CMC without further incident. Patient heart rate did increase throughout the transport, reaching a maximum of 130. When we dropped him off, he had a heart rate of about 115 to 120. We arrived at CMC, fast exam was done, and it revealed a positive fast. Patient went to the OR, and the details after he got to the OR are kind of sketchy. What we do know is that once he got opened up, they couldn't find the source of the bleeding, and he subsequently died as a result of his injuries. I don't know if he died in the OR, and I don't know if he died in the ICU. Discussion. What did we not do? We did not give blood or fluid for this patient. We did not treat his hypotension the way it should have been treated, and that's as if he was hypovolemic shock. And why didn't we do that? Because the referring physician said that he was neurogenic shock. The injury suggested that he was neurogenic shock. The physical assessment that we had, injuries only to his head and only to his neck, no injuries to his chest or abdomen, no bruising or anything noted, led us to believe that all of his injuries were head and neck. So we got going down that line of thinking that this is all he has, so we did not treat him for hypovolemic shock. What we learned, unless there is an absolute definitive reason not to suspect ongoing blood loss, always treat any hypotensive patient, trauma patient, as if they were bleeding somewhere. Give fluid, and if indicated, give blood. And it was certainly indicated in this patient. He had received 5 liters of blood, or 5 liters of normal saline before we got there. More discussion. Signs that the patient was not in neurogenic shock. One was the tachycardia. We attributed that to the dopamine that we started. once we started and got to our maximum dose, he got to 130. When we titrated that down to 12.5, he actually got into the 110s, 115 or so. So even though we were thinking that it was because of the dopamine, it's probably because he was hypovolemic. And the other thing was the cold and pale skin. Neurogenic shock patients, you want to expect warm, dry skin. Cold and pale is more in line with a patient that you're going to see that's in hypovolemic shock. References used for this presentation are here and here. If you guys would like more information for neurogenic shock, just let me know. I have a huge library of things now after doing the research on this that I did. So anything else that you would want to know, any more numbers, especially from Tarn, let me know and I can get that for you guys. Thank you guys. If you have any questions or comments, you can email me or contact me however you wish. Have a good day.